I have the honor of introducing our keynote speaker tonight, Mr. Jesse Milan. Jesse is the president and CEO of AIDS United, a national organization focused on ending the HIV epidemic in the United States. He is a person living with HIV for over 30 years and a recognized leader in the HIV community. Aids United has a 30-year legacy of granting over $120 million, including $8 million currently, to over 250 grantees in 40 states and territories, and the 55 members of its public policy council that are leading the HIV organizations in the country. Mr. Milan also is just such a wonderful individual. I have had nothing but great interactions with him, albeit all virtually. I was looking forward to meeting him, but we welcome you with open arms here to AMSA, and we cannot wait to hear your message. Thank you so much.
Well, thank you, Isaiah, for that lovely introduction. And good evening, everyone. I want to start with a confession that I'm a bit trepidatious about speaking to all of you, particularly in the midst of this national trauma of COVID-19. I usually start a keynote or a speech like this with a little bit of humor, but I don't think any of us are in a humorous mood tonight. I'm also a little trepidatious because Isaiah didn't mention it, but I'm a lawyer, and I'm a little trepidatious about being the only lawyer in this Zoom meeting, and also about being the only baby boomer, perhaps, where my technical skills might be on display. But nonetheless, I consider tonight and this opportunity, especially in the context of our national trauma, as a sacred trust. And so it is a real privilege for me to speak to you, and I am very, very humbled by this opportunity. And those are what I want to talk to you about tonight. Trust as it relates to trauma, trust as it relates to privilege, and trust as it relates to humility. But first, I want to bring you a word. As you heard from Isaiah, I'm CEO of AIDS United, a national organization focused on HIV and AIDS, and I meet regularly with other CEOs who are in the social justice movement, in the LGBTQ movement, and in the public health movement. And I met with many of them just this week, and I asked them, what message would you like me to bring to you tonight? And resoundingly, they had one word: thanks. Thank you for your calling as physicians, and thank you for all that you're doing in this COVID-19 trauma. But I was not asked by Isaiah and AMSA to speak to you about organizations or to represent organizations. I was asked to represent people tonight. People who are on the margins and people who are socially marginalized. People who are socially marginalized. And they come in all races and colors, both men and women. My people are of same gender-loving experience and also of opposite and both gender-loving experience. They are of transgender experience. Some have experience as substance abusers or injection drug use, and some are even sex workers. All of them are part of my group of people who live with HIV, about 1.2 million people in the United States living with HIV, and they're part of the larger group of another 1.1 million who the CDC tells us are vulnerable to HIV. And if you're vulnerable to HIV, you're vulnerable to the dozens of sexually transmitted infections, of which there are 20 million in the United States every year, half of whom are among people between the ages of 15 and 24. And one of the most prevalent sexually transmitted diseases is, of course, hepatitis. Hepatitis. Between 2.5 and 5 million Americans have some form of hepatitis, and 2/3 of them don't even know it, and about half of them are like me, baby boomers. So I do represent tonight people who are both young and old, men and women, boys and girls. Some of them have private insurance. Some of them have Medicaid or Medicare. A lot of them have no insurance. Some have jobs, and increasingly more and more have no jobs at all. Some were born here. Some came here or were even brought here, some with documentation and some with not. But all of these people, all of my people living on the margins and marginalized have one big question for you. And that is, can I trust you? Can I trust you? Now, I'll tell you, I had a bit of trepidation about choosing that theme for tonight, but it actually came to me from someone who's as much a part of your community as my community, because the person is a former member of AMSA who has become a well-known doctor in my arena. In fact, he just finished serving as head of one of the most important international organizations focused on HIV and AIDS. And he was at my home in the very same month that I received this invitation to speak to you, but he was in my home with my husband and 2 mutual friends so that we could comfort him because he had recently lost his husband because of a medical condition and medical circumstances that I don't really understand. But years before, he also, like me, lost our partner to AIDS. And so I asked him, because of all that we have in common, what theme should I use for tonight? And he became very solemn, and his eyes became damp. And he said, can I trust you? And in that moment, I pondered, was it because he and I represent so many people in common who want to trust you? Or was it because he and I both had that experience of being by the bedside of a partner we loved and wondering who we could trust? Or was it because, as a physician, he has been on the receiving end of great trust? To be on the receiving end of trust, to earn trust, is a sacred thing. But it's not the same as receiving or earning respect or appreciation or even deference. Those might come to us because of our privilege, the privilege of our schooling and our degrees, of the color and length of our coats or my suits, or the responsibilities we have or the titles we have, or in my case, even my corner office, which I dearly love and can't wait to get back to. Those might be marks of our privilege and even of our power. But those are also marks of respect and appreciation, and maybe why people should defer to us, but not necessarily why they should trust. Now, I want to explore this just a bit by asking all of you to imagine what we have seen literally every night for the last month and a half. On our TV screens, we see the president standing at a podium, and next to him, Dr. Debbie Burks, and next on the other side, Dr. Tony Fauci. A perfect example of privilege and power, also an example of respect and appreciation and even deference. But who in that picture do you trust? If you don't know, Dr. Debbie Burks is our global AIDS ambassador. And she runs the $6 billion PEPFAR program, the President's Emergency Plan for AIDS Relief. and I have the privilege of serving on Dr. Burks's scientific advisory board. I know that Debbie is deeply committed to teaching, to advocacy, and to learning, and she as a mother is passionately committed to women and girls who are vulnerable to HIV. And Dr. Fauci, wow, he's my people's hero. We had the opportunity in October to celebrate Dr. Fauci when my organization, AIDS United's Public Policy Council, celebrated its 35th anniversary. It happened to coincide with Dr. Fauci's 35th anniversary as director of the National Institute of Allergies and Infectious Diseases at NIH. And so Tony gave a wonderful thank you when I got to present an award to him. And what I've done with Tony is that I've had the opportunity so often to hear him speak, and he shares his own picture. He always shares a picture when he's talking to my people of him from nearly 40 years ago, standing next to the bed of a man dying of AIDS. And I think he uses that picture to remind us, to remind my people of just how committed he is to us, to our living and thriving. And I think he uses it to remind himself that he's always about the person and not the disease. So when Tony spoke in front of a conference like this of my people about the concept of you equals you, which means your HIV, if it's undetectable, is untransmittable to someone else, my people stood and applauded. We cheered, we cried, because we know how much Tony knows us and appreciates that we don't want to pass this virus on to anyone else. We believed him because we trust him. All of us, all across the country tonight, are longing for who we can trust. But my people have histories of mistrust. Mistrust that predates COVID-19, generations and generations passing on mistrust, and people passing around why we should mistrust today. I want to tell you that just a few weeks ago, I explored this mistrust at a conference at Tuskegee University. And the summit was titled Medical Mistrust and HIV. This was about 6 weeks ago, not 60 years ago. And I'm going to tell you why it was at Tuskegee in just a moment. So at this conference, we explored why this medical mistrust has resulted in such amazing health disparities for African Americans and HIV/AIDS, disparities that are on top of the social determinants of health, of racism and poverty and unemployment and lack of insurance. All of those certainly contribute, but the notorious Tuskegee syphilis study, creating mistrust, also contributes to it. Now, if you don't know, the Tuskegee syphilis study concerned this. 600 men, Black men, were recruited to study untreated syphilis in Black men. Those 600 were chosen, but never told that they had syphilis. They were merely told they had bad blood. And they were recruited with the promise of a lifetime of healthcare and even free burial insurance. But when a treatment for syphilis was discovered, they were never given it. And that study lasted for 40 years, from 1932 to 1972. So mistrust about this notorious study has been passed around, so much so that the acting president of Tuskegee came to the opening of the summit just to set the record straight. She said this was not a study by Tuskegee. In fact, the actual name of the study is the U.S. public health service study on syphilis at Tuskegee, not by Tuskegee. And this mistrust of health professionals, of public health, and of our government continues today in the African American community. In fact, I get to sit in a lot of Ubers, and when I tell them what I do, you'd be surprised how many Black Uber drivers today ask me, well, is it true that HIV was discovered by the government to kill Black people? That's how much mistrust continues. And when I got back from that study at that summit at Tuskegee, I went to another summit for the Latino community, the Latinx summit on HIV and AIDS. And I heard about their mistrust, which is being exemplified right now at the border, where health professionals and public health and government are failing brown people. And even in China, this article in Time magazine in February explores the outbreak in Wuhan, and in its second paragraph, it describes the distrust of the Chinese in their government that may have precipitated that outbreak. But it's not just people of color or people of racial backgrounds that have this distrust. My people's distrust transcends across the LGBTQ community, and it's happening right now. An organization in New York called The Lighthouse, whose focus is on connecting LGBTQ people to healthcare, reports a study showing that over the course of my people's lifetime, 56% of us will have experienced some sort of stigma or discrimination in healthcare. And some of us, as many as 1 in 4, may have had that experience within the past year. Those happen when we reveal who our sex partner is or our sexuality. But one of your members, one of you, had a wonderful article not long ago. Dr. Brett Torelli, who was an MD candidate at Washington University in St. Louis, wrote an article in which he said that when you do have conversations about sex or sexuality, you actually, his words, engender trust, because it becomes clear that speaking to you is a safe space. But is it? Two of my fellow CEOs, Rhea Carey and Mara Kiesling, one who runs the National LGBTQ Task Force and the other who runs the National Center on Transgendered Equity, their two organizations did a 50-state study of 6,000 transgender people and discovered the rampant experience of harassment or of health providers flat out refusing to treat them. And among the lesbian communities, high percentage of our sisters refuse to even try to seek care because they fear discrimination. And there may be reason. The American Journal of Public Health recently published a 2015 study showing that 80% of first-year medical students had an implicit bias against LGBTQ, and as many as 50% had an express bias against LGBTQ people. And Stanford Medical School in the same year in 2015 reported a study showing that 40% of medical students who self-identify as not heterosexual also feared bias by their faculty, by their peers, and maybe even by their patients. So do you think my people don't know that? And has that much really changed in these last 5 years? Well, what has happened in these last 4 years is that the Trump administration has actually begun to sanction stigma and discrimination against LGBTQ people. This very same administration that's leading the charge against COVID-19 is purported to be leading the charge to end the HIV epidemic. In fact, 14 months ago, President Trump, in his State of the Union address, announced the Ending the Epidemic initiative to bring new money to ending the HIV epidemic in America by 2030. And it has galvanized my peers and my fellow organizations. But just 2 months later, his Secretary of Health and Human Services, Mr. Alex Azar, he's the guy with the brown and gray beard who also stands next to Dr. Fauci. He released a rule on behalf of HHS that would protect healthcare professionals and healthcare institutions against claims of discrimination when they deny or refuse care based on their religious conscience. And I wonder who those people would be. 6 months later, Secretary Azar released another rule, turning back Obama-era protections for the LGBTQ community against discrimination by any Department of Health and Human Services grantee. Health and Human Service Department grantees, that's a $7 billion industry where now we might be sanctioning discrimination. Thank goodness courts are working on that. But all of these efforts to discriminate and to sanction discrimination are traumatizing to my people. They're traumatizing, they're affronts to our dignity and to our human rights. But my people already live on top of mountains of trauma from the AIDS epidemic. Let me tell you, every time I hear the term the virus, I'm traumatized, because back in my day, we often didn't use the word AIDS in polite company. We referred to it as the virus. I think he has the virus. He died of the virus. Aren't you worried about the virus? And every time I see someone putting on a gown and glove and mask, I'm taken right back to the night that my priest put on a gown and gloves and mask to give the last rites to my partner. I'm re-traumatized. And my people already have experiences of trauma of rape and incarceration and addiction and bullying and cyberbullying and intimate partner violence and rejection by our families and even murder. My closest friends and I remember every Easter our friend who was murdered and left on the side of the road and was not found for 3 days. And the suicide rate among our people, especially our youth, are 4 and 5 times higher than for heterosexual youth. So when I walk into a room or a Zoom, how do I create trust? Can they trust me? Can they trust you? And why should they if our default is because of our privileges, like our degrees, or our titles, or the color and length of our coats, or the number of suits in my closet? Well, let's explore that a little bit more, because that TV picture of the president and Dr. Burks and Dr. Fauci is a perfect picture of privilege, respect, appreciation, and deference. But who in that picture do you trust the least? The Daily Beast, which is a major news and editorial service online, had an article with this headline just a few weeks ago. In Dr. Fauci, we trust. A Latina advocate in my movement got to meet Dr. Fauci at that 35th anniversary event. And she watches him every night on television. And when I talked to her last week, she said to me this. She said, I would trust that man with my life. And I think this is why. Trust is built when we are led or supported as we believe in our soul instinctively and viscerally that we are being led as we need to be, or being supported as we want to be. And let me tell you, if you don't have that instinct, that visceral response of trust to the person you're dating, trust me, move on. If you can't trust the person you're dating with the last penny in your pocket or the last drop of your blood, move on. But marriage is a subject for another conference. As a patient, I may choose you because you're the best, but I will trust you when I believe you understand what I need to thrive. I think Maya Angelou said it best when she said, "You will not remember what someone said. You will not remember what someone did, but you will remember how someone made you feel." And how we feel trust may not come from your power. It just might come from your humility. And so I'd like to end today by talking about a new concept called cultural humility that I hope is helpful to you. And I want to unpack it for a bit. You know, we talk a lot about cultural competence, as though you can get a certification or a certain grade, a finite piece of learning about another people or population. Like we can learn their lingo and their history, like understanding that I've gone from colored to Negro to Black to African American, or that the Latino community prefers the title Latinx community today, or even that when I was younger, the term queer was an insult, and now we're all referred to each other as the queer community. But I might still prefer to be called gay rather than queer. And there might be some Black Republicans, and yes, they do exist, of my father's age, who might still prefer to be called Negro rather than Black. But you won't know if you don't ask. And that's what cultural humility is about. You never know enough because people and cultures evolve. And recognizing that what you do know may be this, but there may be things that you don't know that you don't know. Making a lifelong commitment to acknowledge that your power and your privilege may be about your identity rather than understanding, committing to the intrapersonal experience of learning and growing from others. Because when you know and understand who a person is, you might understand better how a person is. I want to give you an example from my own life. I used my privilege to get referred to who at the time was the best doctor in the country, or so I was told, to treat HIV and AIDS. His name was Dr. John Bartlett at Johns Hopkins University. I had a privilege of knowing someone who knew him so well that he went to Dr. Bartlett to recommend that he take me on as a personal patient, and he did. And I loved seeing Dr. Bartlett at Johns Hopkins. He and I had wonderful conversations, but then over a period of time, I became increasingly uncomfortable because I felt that Dr. Bartlett was seeing me through only one identity. And finally, one day, I scrunched up my own power and I said to him, "Dr. Bartlett, don't you think as a Black man over 40, we should be thinking about something other than just my HIV?" His response, but I give John credit. He recovered in a nanosecond and he said, "Why, Jesse, I think you're right." And he referred me to someone he trusted who could look at a bigger picture of me. And today, when I see Dr. Joseph Cofrancesco at Johns Hopkins, and I say, "Dr. Cofrancesco, I want to get my husband on the phone for this conversation," he understands what I need to thrive. Can I trust you? My people have so much experience of trauma, of stigma, of discrimination, and of acts under the power and privilege of others, that this question, can I trust you, is on our hearts and minds when we enter the workplace, when we go any place, including when we're in a place with you. But my hope is that you might have a new question, and that might be, what can I do not to earn your respect or your appreciation or your deference? What can I do to earn your trust? I'm learning in my own life that this is a very humbling question, but it just might be a good place to start. Tonight, all across the country, in all 50 states, people are wondering, who can we trust? People are afraid that there will be no one to hold their hand or to kiss their brow when they reach the end, wondering, who can I trust? I hope you know who I hope the answer will be. So thank you. Thank you for all you are doing and for all you will do in your careers. By your listening and by your watching tonight, I hope that wherever you practice, when my people have the privilege to be treated by you, they will feel in their bones that yes, I can trust you. God bless you. God bless you for your work, and Godspeed for all of us in this COVID-19 crisis. Thank you all. Good night.
Mr. Milan, thank you so much. I know that AMSA and SNMA definitely trust you. That is such a powerful message for young and future physicians. I have a few questions for you, Mr. Milan, and I'm going to jump right into them so that we can get to as many as we can. The first one is from TJ Law. Mr. Milan, thank you so much for speaking with us tonight. Simply inspiring. I wanted to ask, what are the top 3 issues students, both pre-medical and medical, need to advocate for in this new decade?
Certainly in this new decade, expansive training on LGBTQ issues and health issues particularly, especially because the HIV community is aging, and currently 50% of that 1.2 million people I mentioned are age 50 and over, and by 2030, 70% of us will be age 50 and over. So treating HIV and aging comorbidities are a new complicated will be complicated, and your ability to understand that both medically and socially and emotionally, I think, would be very helpful. So expanded training on LGBTQ issues, and I think becoming knowledgeable about the healthcare payer system. You know, we're having a big national conversation about that right now, but it is helpful to understand from inside your work what the difference might be between Medicare and Medicaid, and be conscious of what those payer issues will be once that patient walks out your door. So I think health policy and health financing and expanded knowledge around LGBTQ will be helpful.
Thank you. Our next question is from Yosa Oronse. Her question is, thank you, Mr. Milan. As a medical student learning proper interview techniques in my first term, my first experience asking about sexual history on a patient left me feeling uncomfortable and unsure of a good approach. What would be your advice on approaching asking the sexual history questions without offending or making the patient uncomfortable?
Well, I think that there will be lots of training modules, and I'm not typically prepared to present one for you tonight, but I do think that having the countenance of humility, because it is such a sensitive topic that if the patient feels that you are probing into a very delicate area, they will appreciate that you're probing into a very delicate area. So I think practicing how you can be present and sincere as opposed to taking down a piece of data, I think that's a good place to start. And I'd be happy to help identify some trainers or training modules that might be useful in your institution.
Thank you. Our next question is from Ben Poholik. Mr. Milan, as a gay man and an advocate for the LGBTQIA plus community, how do you reconcile the emotional strain of arguing for your and your community's rights while pushing forwards towards the goals of your activism?
You know, we can't do this work alone. Your work is hard, and boy, we're seeing that every night on the television. So is mine, but finding a support system that empowers you to be all you need to be professionally and personally, I think is true for all of us, no matter what our calling is. I have a husband. I have a group of very close and dear friends who support me. I also have a faith community that's behind me, and don't underestimate the power of having a faith community behind you. Those keep me going. And they also catch me when I start to fall, and they reassure me and strengthen me. So a support system is helpful for all of us.
Our next question is from Keenan McGonigal. How do we, as privileged future health professionals, partner with historically marginalized communities without speaking for them or without them when advocating for health justice?
So in the HIV movement, we have had this mantra for literally 40 years. Nothing for us without us. I once heard, if you're not at the table, bring a folding chair. So the more that you invite to actually be at the table where plans and decisions are made, the more you empower those who you want to not represent, but whose concerns you hope to address. If we're not represented at the table in significant numbers, then it will be as though we're operating from ancient paternalism where, oh, I know what you need and I'm going to tell you and this is what you get. Bring them to the table, make them bring their voice, invite them to do so.
I'm going to ask one final question. I am sorry that I know there's a lot that came in. I apologize for not being able to ask all of them, but I think this is really, really simple and pertinent. What do you think are the first steps in rebuilding trust as physicians, as we are a group that at times has lost trust due to our actions in the past?
The first step, and I'm more than happy with my organization, AIDS United, to come and provide a broader sense of this concept and this training. But a first step is to recognize what privilege you have, what privilege you hold, and the power that it creates within every encounter. And the more you recognize what you don't know that you can learn from the other is, I think, the first step. So just be conscious that there's a power dynamic created just by what you're wearing, who you are when you walk in the room, and understanding that alone may be the first step.
Thank you so much, Mr. Milan, for joining us tonight. I know that everyone enjoyed this, so inspiring, and we wish you and your family and those around you well. I have a few.
Isaiah, thank you for your leadership, and thank you to everyone at AMSA for giving me this tremendous opportunity.